Hello everyone, and we'll be discussing the 24th case of this case discussion series, and it's a very interesting case. So here we have a 44-year-old female who came with complaints of blurring of vision and headache since the past 6 months, and this is the MRI brain done for this patient. So these are the T2 weighted images, axial section, where we can see that there is a heterogeneous lesion that is seen in bilateral temporal region and the sellar region, and there is some edema that is seen in the adjacent white matter. These are the FLAIR images where we can see that there is extensive edema in the left cerebral white matter causing effacement of the left frontal horn of the left lateral ventricle, and we can see this lesion. These are the T1 weighted images where this lesion is predominantly iso-intense to the gray matter, and in bilateral temporal region and sellar region. These are T1 post contrast images where we can see that this sellar mass is actually extending to the bilateral temporal region. These are the coronal images where we can see this mass very well, and it is encasing the intracavernous portion of the bilateral internal carotid artery here. Again, the T1 post contrast images where we can see that there is complete encasement of the intracavernous ICA. These are the MRS images where we can see that within the lesion there is a choline peak and reduced NAA and a lipid lactate peak at some places, suggesting areas of necrosis within the tumor. So this is a report that I had given, that there was a large heterogeneously enhancing sellar mass lesion with suprasellar extension into bilateral temporal regions, where there was extension to the left temporal region more than that of right. The mass lesion encased the intracavernous portion of bilateral internal carotid arteries measuring more than 270 degrees with no significant luminal narrowing, which suggests that there is cavernous sinus invasion. There was no pituitary gland that was visualized separate from the lesion, hence this was a pituitary lesion, and the lesion predominantly appeared iso-intense to gray matter on T1 and hetero-intense on T2, with no evident restriction on DWI or any foci of blooming on GRE. The lesion compressed the optic chiasma superiorly, because of which the patient had blurring of the vision, and it exhibited extensive edema on the surrounding adjacent left cerebral white matter, causing effacement of the frontal horn of the left lateral ventricle, which was seen on the axial as well as the coronal images. And on MRS, it showed a choline peak with reduced NAA and lipid lactate peak in some areas, suggesting tumor with some necrotic areas. Features were suggestive of invasive pituitary macroadenoma, NOSP grade 4. What exactly is NOSP grading? So NOSP classification gives 4 grades, where we draw 3 lines relation to carotid. There is a medial tangent in the medial wall of the carotid, then there is an intercarotid line, and then there is a lateral tangent. Any tumor which is medial to the medial tangent is grade 0. Between the medial tangent and intercarotid line, if the tumor extends, it is grade 1. Between the intercarotid line and the lateral tangent, it is grade 2. Grade 3 is beyond the lateral tangent. If it is above, that is superior cavernous sinus compartment, it is 3A. Inferior cavernous sinus compartment, that is below, is 3B. 4 is complete encasement of ICA, which was seen in this particular case. So this was a NOSP grade 4 invasive macroadenoma.